Good afternoon, everyone. Pediatric Center of Excellence in HIV Care at LTMGH and LTMMC, Sion, Mumbai welcomes all the participants for today's RDLS session. Today's topic is screening and diagnosis of TB in CLHIV, and the speaker is Dr. Yashwant Gabhale. Dr. Yashwant sir is the additional professor with the Department of Pediatrics and the program director of the pCoE. He is also in charge of Nutrition Rehabilitation Research and Training Center, that is NRRTC. His areas of special interest include pediatric nutrition, pediatric HIV, and pediatric asthma. We welcome you, sir, for today's session and request you to start the session.
Good afternoon and सर्वांना गणपती बाप्पाच्या आगमनाच्या हार्दिक शुभेच्छा आणि I hope that today there will be less speakers, but as Shweta has suggested that it will be recorded and the link will be sent to those who are not attended today. And today's topic is very, very important. That is screening and diagnosis of TB in CLHIV. As a pediatrician, we see lots of cases which are being referred to us because we are a tertiary care center and we are a model center. Plus, we are the center of excellence. So we see many cases who are not diagnosed properly because they are having difficulties in diagnosis. Because many of the centers and the periphery don't have a ability of pediatricians or expert opinion. So let's see how we are able to cope up with screening those children and starting them on right time the TB treatment. Next slide. So this is our flow for today's discussion. So we'll be also discussing about what is the TB incidence in India and what are our targets, because you are aware that there is 40% of chance overall for all children who are HIV infected that they will get tuberculosis over a period of time. So there are various challenges are there, right from diagnosis to the starting of treatment. And as all of you are aware that there is lots of differential diagnoses are there in TB, like pulmonary, extrapulmonary TB, and lots of tests which are included for confirmation of this test. Next. So this is what we had planned, that we want to end TB at end TB targets by 2025. So at least you can see here 80% of reduction of the TB incidence rate, which has been achieved as compared to 2015. And also there is a 90% reduction in the TB mortality rate. And plus we are also going to target a zero TB affected household suffering from these catastrophic expenses due to tuberculosis. And that's why there are various incentives also be given to the children or the person who is on TB treatment, so that they are able to complete this treatment. If you can see that our baseline in 2015 was 217, with a range of 112 to 355. The target which was there was 77, and with what we achieved in 2020 was 199. And you see the Western mortality due to TB was somewhere around 32, which has set the target of 6, but which are not achieved for that. That achievement was 23. And to ensure the family should have minimal suffering from this TB was around 35%. So target was around what they have achieved. Next. So it is a tip of the iceberg, because the children get the TB usually from the adults. Therefore, if the adults are not treated properly, the children are going to suffer, and especially the children who are less than 5 years of age, if they are malnourished or if they are HIV. So if HIV and malnutrition is there, then there is a more high risk for these children. And these children, if they don't get diagnosed early, there is high mortality rate. If you can see this right side of diagram, between 0 to 4 years, the reported cases, if you see, they are around 42, but missing were around 58. Why? Why there is so much of missing cases? Because small children don't complain. So you have to be more observant, because clinical signs you to pick up in these children. They might be having fever, cough, cold, or if they goes for more than 2 weeks of duration, they have to be thoroughly investigated, including a thorough clinical examination. Because many of the people don't palpate even cervical axial lymph node, because sometimes it can be a extra pulmonary tuberculosis. A small or big lymph node sitting in the axilla is there, or the cervical region is there. You have to undress the child and see for this. So this is why it is very important, especially the children who are less than 5 years of age. There you can miss many cases. And if you can see next bar, which is between 5 to 14 years, since it is a older age group, uh, less cases were missed as compared to the younger 0 to 4 years of age. And more than 15 years, obviously they can come up with their own symptoms and they can assess the health facility. That's why they are reported most often. Next. So there is a huge detection gap in the under 5 age group, which is strikingly highlighted in this diagram. Next. This is another state from 2012. If you can see the data till 2023. So see the incidence of the TB. Again, it is reporting of the cases is more important because annually, if you see 5 to 7% of all TB patients notified under National Tuberculosis Elimination Program, that is NTP, are children. Contractions are expected of 10 to 12%. So less number are still reported. Why this is done? Because many of the children they are mainly dependent on adults. They are not brought to the healthcare properly, and therefore they are having high morbidity and mortality subsequently. So if you see the pediatric TB noted in 2023, between 0 to 14 years of age, around 1.4 lakh pediatric TB patients were diagnosed. Pulmonary TB was the most prevalent and the external TB. And as per the next year data, EPTP cases in the pediatric age group is around 44%. And plus the pediatric DRTB, drug-resistant TB is also one of the things which is increasing because adult DRTB is increasing. That's why we are getting pediatric DRTB. And there are around 2,108 MDR or RIFA-resistant TB cases, 348 H, that is mono or polypediatric DRTB cases were diagnosed. So therefore, reporting and then completing treatment, it is a huge task for as a clinician when it comes to pediatric HIV. Next. So why there is a huge gap? As I said, that often the under diagnosed and underreported due to lack of simple sensitive point of care tests. And smaller children, it is very difficult sometimes to diagnose also. Therefore, a program has to be organized for children because this program, when it was started, TB elimination was more adult cases oriented program was there. And then we are told that childhood TB is the same, but it has different clinical presentation. Therefore, needs to be have more specific guidelines. Then the guidelines came into picture, and the childhood TB now we're getting more and more to be getting diagnosed, and plus the sensitivity of the test has also been increased over a period of time. Maybe it be a bacteriological or radiological. Now we got, if in doubt, we can do a CT and confirm the diagnosis because sometimes the XHS may not tell you the lymph node whether it's just plain lymph node, infected lymph node due to TB, or it is due to other etiology or bacterial etiology. So there you can get an answer by doing a city chase for the child. Next. So as I said, radiologically also, one has to be sharpened with seeing more and more cases, and chest X-ray interpretation has required more and more expertise opinion. And if the person or the clinician is not oriented to that, he may miss a patch or a simple lymph node also higher lymphadenopathy. And as if the child is HIV infected, then you may have to also prove it with this culture, sputum culture. If the child has a normal chest radiograph, if you are highly suspected TB, so cultures and radiography has to be correlated. If suppose you have a strong suspicion, then you may go ahead with the cultures. You are thinking the child is having a TB. So sputum has poor sensitivity in detecting TB, and now we have nucleic acid amplification test, that is NAT is the front line test which is available at diagnosis of TB in CLHIV. And if the NAT is not available, then we can go ahead with the other nucleic acid amplification test or microbial growth indicator, that is midget, we call culture. This can be done for the child. Next. So as I said, that pediatric TB is the direct consequences of the adult TB. Therefore, adults have to be screened whenever possible in a family. And whenever a child comes for who is newly diagnosed, we always do this 4A screening, and we first rule out the TB. And we also ask the family history. In pediatric, we are always proud of family history. If anybody is having TB, all family members has to be screened for tuberculosis. And if you require, they might have to go for culture sensitivity also. So TB and HIV can present with similar symptoms in children, leading to delayed or misdiagnosis. And over a period of time, we have also seen that drug-resistant TB is also increasing in our pediatric population. Next. So risk of TB in children who are living with HIV, as I said, is over a period of time, 30 to 40% is the overall chance that this all children will develop TB at some or the other point of time. So it can be a primary progressive TB, or it can be extrapulmonary TB or drug-resistant TB, or they can be a higher case fatality rate when it comes to TB. Next. So when you come for a diagnosis of TB in children, so your approach should be there. You should be having a very careful history. A detailed clinical examination has to be there from head to toe examination, including your cervical, axillary, inguinal, lymphadenopathy, hepatosplenomegaly if it is there, any sinus is there on the body, has to be looked for. And if in doubt, if there is no pediatrician there, you can always refer this case for a pediatric opinion. Then bacteriology confirmation is always to be done whenever possible. And obviously, we are also having a radiation. A plain simple X-ray sometimes can be telling you if it is miliary or if child has any collapse consolidation or bronchiectasis or island hemorrhagopathy. And whenever possible, if you want to go for a culture, please go ahead in children, especially if it is a pulmonary TB. And if it is PTB, then if it is lymph node, then FNSC or biopsy of that lymph node can be done. Because sometimes you can miss a diagnosis of lymphoma also. Because non-Hodgkin lymphoma also we have seen in a couple of cases where the child was treated for TB, but it was not a TB, then there was no detection of lymph node. And then finally, when the child came to us, we strongly suspected that it is NHL, and we did the biopsy, and the child turned out to be non-Hodgkin lymphoma, and they started the treatment. Next. So clinical features of pulmonary TB can be a fever, persistent cough, failure to thrive. Failure to thrive means there is not gaining weight. And then there are two categories. One is the weight loss. What is weight loss? A weight loss can be defined as more than 5% of the body weight, which is as compared to the highest weight which was recorded in the last 3 months. If he has a recorded weight in the last 3 months is there, and if he has not gained the weight or he has reduction in the weight, if it is 5%, then it is called as weight loss. Overweight gain is that no weight gain in past 3 months. His weight is not increased by hardly by 200, 300 grams also. It is also a poor weight gain. Contact with the TB is a case where the child has a nearest contact who is having active TB in the last 2 years. As all of you are aware, if a person is having a TB contact, the bacilli may enter in his body, and depending upon his immunity, it may not manifest that time, but over a period of time, a person may manifest the disease. The child also can have a lymph node enlargement if it is extrapulmonary TB. Therefore, careful examination when you do head to toe examination, then you look for the cervical, axillary, inguinal lymphadenopathy. If child is having a TB meningitis, he may be having a headache, or if it is a later stage, he can have confusion, coma. Suppose it is a bone TB, the child may have a joint pain or back pain or spinal deformity, cox spine, what we call. if it is a lung affection, the child can have a chest pain, tightening the chest. If there's pleural effusion, severe pleural effusion or massive pleural effusion, you can have a respiratory distress. Or there's a pericardial affected, you can have a heart rate affection, pericardial rub will be there. Clinically, you can hear that rub or cardiomegaly will be there, which can be detected on 2D echoes of pericardial effusion. Uh, if it is a abdominal affection where the child can have a abdominal pain or ascites will be there. If it is a severe ascites, child can have a respiratory distress due to the massive ascites. So contact with a TB case has to be traced and that person has to be also be treated. It's a holistic approach where we have to approach when we are coming with a TB to a child. Next. So what are the atypical features of TB? So it can be extrapulmonary or miliary TB, which can be very common in some of the younger children. And these children can also present with the localized pulmonary infiltrates with highly lipidopathy. 24% of the children may show involvement of more than one lobe of the lung. And middle lobe collapse or consolidation can result in endobronchial tuberculosis, which can be very prominent on the X-ray. And older children and adolescents may present with the cavitated tuberculosis. And this cavitated tuberculosis sometimes can have hemoptysis also in our later stages. Next. Now coming to our screening at as an ART center, we have a 4 symptom screening, which is done by our staff nurse when the child present to us for the treatment. So there we ask for a fever, so any type of fever, high grade, low grade, moderate grade fever has to be there. Or if the child has current cough, or he has a poor weight gain, as I said, that weight loss or not gaining weight is there, and plus there is a contact with a TB case, then it is known as 4S positive. So this 4S positive child then finally has to be confirmed for tuberculosis, whether he has TB or no TB. Next. So this child is further investigated for tuberculosis. Next. So all this CLHIV we are screening for TB in our ART centers, and if the all 4S above 4 symptoms are absent, then we stamp them as 4S negative. And if it is 4S positive, then this child needs to be investigated further by our medical officer for confirmation of TB. Next. So just to have a case scenario, here is a case that Master A, who is a 4-year-old child, and he has presented with cough and fever for 1 month. His mother has completed treatment of pulmonary TB recently 1 year ago, and then further on clinical examination, the child is weighing around 13 kg with a height of 95 centimeter. Child has oral candidiasis, cervical lymphedema, liver is patho, which is 3 centimeters, spleen is also 1 centimeter. His vitals, the respiratory rate was showing 32 per minute. So 4-year child having a mild tachypnea is there, and chest is clinically clear. So question number comes to our mind that what is the 4S screening in this child? Next. So 4S positive is there. So I will label this child as present to TB case. And the next question come to my mind that how do we proceed as to evaluate this TB in this child? Next. So here is a chart which is given, and if we look from top to bottom, first we take a child who is HIV infected. So he undergoes the 4S TB screening. Cursor, please. Cursor. So he goes for undergoes 4S TB screening. What is it? Cursor. So he undergoes 4S TB screening. Then 4S, any of the symptom is present, such as I mentioned, fever, cough, weight loss, or TB contact. Okay, then his 4 is positive. Then clinical evaluation is done by the medical officer. And if it's presumptive TB, permanent TB, then he will subject for NAT or smears or X-ray test. Suppose the NAT smear or culture is positive, then it will be labeled as child is microbially confirmed TB case. Suppose NAT smear negative and chest is such of TB, then it will be labeled as clinically diagnosed TB because his cultures are negative, but clinically his X-ray was such of TB and is diagnosed as tuberculosis. Next scenario, the child may have a chest X-ray and NAT smear both are negative. Then this child simply labeled as no TB. He might be having other viral cause, that's why he was having cough, fever. Okay. And suppose he is present to extrapulmonary TB. Extrapulmonary TB is there, like he may have cervical lymphadenopathy is there, bone is affected. So NAT smear or culture positive from any extrapulmonary site, suppose lymph node is there, or his histological examination lymph node, or his chest X-ray and other relevant imaging is there. Any one more of this above, search of TB, then I will treat this child as extrapulmonary TB. So on the left hand side, if you can see in this box, so cause found for fever like short duration of fever, malaria, dengue, you are a viral. This can also present with short duration of fever. And in extrapulmonary TB also, sometimes organization environment symptoms and signs like swelling of lymph node pain, swelling on joint, neck stiffness, or disorientation has to be noted down. Sometimes the child may have a normal cough cold, its tonsils are enlarged, and because of that, it may having a cervical lymphadenopathy. So that if it is self-limiting and it is not persistent and subside with antibiotic, it is not TB. All lymph nodes are not TB, but you have to investigate in a CLHIV because there are highly chances that it could be TB when it comes to a CLHIV because they are more prone for tuberculosis. Next. Now coming to the most important aspect, that is gastric aspirate or induced sputum. It is said that if the child is less than 3 years, it is better to do a gastric aspirate. So in this aspirate, what we do a fasting at least 4 to 6 hours for the child. The child is called in the early morning, and 2 early morning samples are collected. A nasogastric tube has been placed in the stomach, and this aspirate which are aspirated is sent for sampling, and this uh, as soon as you collect the sample needs to be transported to laboratory because if you keep for longer duration, there might be a chance of contamination. And it is said that the children who are more than 3 years old who can cooperate, then they can be given 3% of saline nebulization, and then they are asked for induced photon sampling and sample should be around 25 ml in the container. So we have Falcon tube which can be given for them, and this can be and then when you are doing an indisputum, you have to be very sure that child is not collecting saliva because it has to be a sputum which is coming from your bronchus. That has to be there. So if the child is not cooperative, we usually collect gastric loss for all the children up to 6 to 7 years of age because I have seen many children don't cooperate with the 3% normal saline nebulization. So this sampling we usually do for children who don't cooperate, gastric loss aspirate, and we send for sampling. Next. So the collected specimen should be transferred to the laboratory as soon as possible to avoid contamination. Next. So there is strategic shift in TB diagnosis, and more effective tests are now available, which can detect the resistance. So old definition of universal drug-sensitive TB was universal access to the rapid DST for at least rifampicin, which was there. But now we have various tests which can further detect the resistance, not only for rifampicin but also for fluoroquinolones. So next. So when it comes for a TB to prove microlesion diagnosis in children, there are some hurdles and there are some solutions. What are hurdles? The child cannot experiment. If that is a hurdle, then we have a simple solution: gastric aspirate. That's what I told that older children, even if they don't experiment, you can go for gastric aspirate. Pediatric TB is possibacillary type. Therefore, there is poor yield on the smear. So in this test, we have molecular test which can amplify a single TB bacillus so can be detected. So amplification test can be used for that. Cultures take long to grow. Now we have liquid cultures, which it is available. So liquid cultures can be used for that. Next. So sampling methods come to permanent TB. If person is going to self-explored, child is going to self-explored, the sputum can be collected. If it is not, then I have chances of collecting by gastric aspirate or induced sputum. If both the fails and I have still strong suspicion, I can do a bronchoscopy. Again, it is a little bit invasive procedure. Child requires sedation. So if required to confirm that, I can go for bronchoalveolar lavage and endobronchial USG based FNSC can be also done, which can give you a tissue diagnosis. And these are the special investigation in certain cases can be used where high clinician suspicion is suspected for TB. Next. So all ART medical officers must look for EPTB and request for reviews such as X-ray, CT, MRI, or organ-specific ultrasonogram for FNSC, other procedures, such as pleural aspirate, pericardial aspirates, gastric aspirates, as per the cases, and the specimen can be sent for the nucleic acid activity test, that test, for the scientific culture examination. Coming to sensitive to NAT for MTB detection. So low to moderately high is there. If it is a pus or aspirates you're sending for the, or it is a biopsy specimen, then there are chances that low to moderate chances of detection of MT will be there. If it is a lymph node or other tissue samples in CSF. If you are very poor in samples which are sent from pericardial, ascitic or synovial fluid, a positive result by culture or NAT provides useful confirmation because it confirms our diagnosis that yes, definitely is a tuberculosis. While a negative culture or NAT cannot rule out TB due to inadequate sensitivity of this test in exogenous assessment. So there you can go for your clinical judgment and if required, you can start treatment if it is highly suspected clinically, but cultures are still negative. Next. So this NTP approved rapid diagnostic tests are there. Once a CLHIV is diagnosed as a case of DRTB, as a reparation or mono, the INH on CVNet or TrueNet, or first line probe assay, that is LPA, the patient is referred to the district TB officer for further resistance testing of this line probe assay and initiation of the appropriate DRTB regimens. If you can see it, and if you guys are having a test which are used CVNet or TrueNet, which is our first choice. Total time taken for this test is around 2 hours. Within 2 hours, we can come to know the result, and therefore we prefer the similar TrueNet test. If you come for first line probe assay, it is the second choice, and it turnaround time is for the testing is 72 hours. Next would be a liquid culture isolation, line probe assay, testing, which takes around 2 to 4 weeks. Then liquid cultures, isolation of liquid DHT takes around 4 to 6 weeks. And lastly is a solid culture or drug testing, which is last resort, which takes around 84 days for confirmation diagnosis. Next. So this is a nucleic acid amplification test, and which is easily available, but a negative NAT does not always rule out TB, and it is highly sensitive and specific test. And then for increased case detection, preferred diagnostic technique among CLHIV, and it also improves the quality of rapid TB diagnosis. Early diagnosis and reduce time taken for treatment initiation. Therefore, it is very popular. It can also detect the rifampicin resistance and minimal biosafety requirements and training needs, and it can be housed in a non-conventional laboratories also. Therefore, this evidence is available at various centers. Next. So coming to the line probe assay, so it is a street-based molecular test which is used to rapidly detect MTP and its resistance to these tuberculous drugs. And it identifies the drug resistance by detecting specific mutations in the bacterial DNA It's performed in laboratory and is not a point of care test. So a little specialized test is there, and it is performed directly on the AMP smear positive specimens or indirectly on the MDP culture isolates. And the turnaround time is around 1 to 3 days, and it can also detect first line the isoniazid information resistance. In second line, it can detect the fluorophilins or second line injectables. So this line probe assay can be also be used if it is available. Next. Now coming to the backtech, microorganism growth integrated tube, that is MIGIT we called. So backtech MIGIT is 960 is a fully automated system for the microbial liquid culture, and it uses MIGIT tubes and it contains liquid broth as a medium and a fluorescence sensor. So whenever the microbial goes in this tube, they try to consume the oxygen, and once this oxygen is consumed, the person in the midget tube can detect this, and therefore intensity of this fluorescence is directly proportional to the extent of oxygen depletion, and therefore the quality assured DST is available for rifampicin, INS, pyrazinamide, oxyfloxacin, levofloxacin, linezolid, amikacin, kanamycin, capreomycin. So the laboratory turnaround time is around 8 to 10 days for a smear positive samples, and it is around 2 to 6 weeks for a smear negative samples. And for drug sensitive after MTB is detected, it is around 1 to 3 weeks for a positive culture. So this midget test can also be used. Next. So this is the standard treatment workflows which is published by the ICMR, where a pediatric tuberculosis specific approach is mentioned, including pediatric abdominal tuberculosis, pediatric intrathoracic tuberculosis, pediatric lymph node TB, pediatric osteoarticular TB, and pediatric tubercular meningitis. So this you can assess by going to the site. The link is already mentioned downstairs. Next. Now coming again to the second case. Here you can see a 3-year boy who is newly diagnosed as HIV positive, has cough and low grade fever for 3 weeks. His body weight is around 9 kg. So for 3 years child, 9 kg is a little low. So he is not gaining weight. CD4 count is also low. To take the percentage, it is 14%, and LP is also low, 8.8 grams. And you can see the right hand side, an X-ray. There is little bit of hilar. Herschel cursor, please. There's hilar lymphadenopathy and lower zone also, right lower zone. You can see a patch is there. Okay. So is he present to TB case? Yes. Next. For forest screening. Next. So it is forest positive present to TB case. Now next is how do we further evaluate this case? Next. So here is again a flow chart is given. If you can see carefully, first if you do an X-ray, then go to right hand side. Chest X-ray is normal. Okay. If chest X-ray is normal, then you check for APTB, like external tuberculosis. Lymph node, axillary or inguinal, you go for a lymph node biopsy and confirm the diagnosis. And then left hand side, if X-ray is suggestive of some consolidation, pneumonia, then I will go for sputum or gastric aspirate or sputum for approved NAT for TB. And if the TB is positive, then I will label this child as microarray confirmed TB case, and then I will further try to know whether it is RIFA resistant or it is not, or it is plain TB, where we just give first line antidiuretic treatment. Suppose child is MTB negative, then look for specifically enlarged lymph nodes or aspirate for the TB, repeat NAT and good sample alternatives or BAL or aspirin as per feasibility may seek for review of higher centers. Then again you go next, of course, chest X-rays showing non-specific shadows, then you give an antibiotic. Many times we do that, that it is just a simple viral pneumonia and with antibiotic it resolves, then there is no need for further uh, issue TB. But suppose this pneumonia doesn't resolve, symptom persists, then again the reverse, you go वरती जा. Then go for sputum gastric aspirate reduce sputum and they go for MTB. इकडे pointer इकडे देणार आहे. या खाली भेटतो. So if it is the next that is pleural effusion. So if child has pleural effusion, then I will aspirate the sample. I will try to do cytology. I want to know whether it is uh, it's pure TB or it is malignancy, because few of the cases we have seen, if the fluid comes as hemorrhagic, then we are confirming that most of the times it is a malignancy. If it is a straw color fluid, we confirm that child is having a exudative effusion, most probably TB, and accordingly we try to also do the cultures, and if MTB is detected or not detected, and clinically also you can start a treatment for this child. Next. So, cases finding which are TB suggestive are hilar or paratracheal lymph nodes, or the significance of interpunctured TB or fabricated TB treatment is there, or million pattern is there. It is taken as confirmed TB diagnosis. Next. So, there are some X-ray which are non-specific, such as effusion, consolidation, bronchopneumonia, or the shadows, which can be also seen in some other viral infection or bacterial infection, but they are not TB. Should also be carefully looked for. Next. So this is that 2-year-old newly diagnosed HIV positive, brought with history of diarrhea, with fever on and off past 2 months and failure to thrive last 2 months. So our individual child was conscious child, weight is around 6 kg. There was signs of severe malnutrition was present. He was lethargic, not able to stand with support. As oral plus some dehydration plus generalized lymphadenopathy was present and had hepatosplenomegaly. So does this child question is has CLHIV needs hospitalization? This is our first question. If you carefully look, this child is a 2-year child. His weight is hardly 6 kg. Plus he has severe signs of malnutrition. Plus he is lethargic, and there is also some dehydration is there. So if you can see IMNC, that is integrated management related to childhood illness, any child who is lethargic, so this is taken as general danger sign positive. Next. So CLHA has signs of serious illness and needs to be referred to the appropriate facility management. So this child needs to be referred to the higher center. If this is just a primary or secondary center, then we may require specialist care. Child may need to be referred to a higher center for further care. So how to evaluate this child for abdominal TB is the next question. Next. So as for the IMNC, I will check for general danger signs. So any child who is not able to drink or breastfeed, or he has persistent vomiting, or convulsions, or he is lethargic or unconscious, or there is stridor in a calm child, these are the general danger signs. And look for signs of severe illness, like child has fast breathing, chest incline, as per his age, cut off. If he is having fast breathing, then it is a child is having severe respiratory distress, severe sunken eyes, skin tint, red flag stories, means severe dehydration. If he has high grade fever, which is more than 37.5 degrees Celsius, or he has signs of meningitis, such as stiff neck or bulging anteropertant leg, or he has a respiratory distress where the saturation is less than 90% in the room air, or any child who has signs of being seriously ill, should be referred to an appropriate facility management as early as possible. Next. So coming to evaluation of abdomen TB, from top to bottom we go ahead. So if the child has abdomen TB suspected, I will look for the peripheral nodes. I will get an X-ray and abdomen USG. Left hand side USG search of TB. Then again to left hand side we see for the chest X-ray. If chest is showing abnormality, then I will do the sputum for gastric aspirate or induced sputum depending on the age. If the child is cooperative, and go for a NAT and TB testing. If it is positive, then I will start a treatment. If it is negative, then the child has to further investigate it whether it is really TB or not TB. Suppose child has peripheral lymph nodes and which is now sent for FNSC or for NAT or TB testing. If it comes out to be positive, then I will start a TB treatment. If it comes out to be negative, again it needs to be evaluated properly. If there are no peripheral nodes or chest X is normal, then and the child has ascites, then I will send acidic fluid for aspiration for cytology, protein, sugar, and I will confirm the diagnosis depending upon the results and whether it is TB or not TB. If it is lymphadenopathy or abdominal mass, whether it is really malignancy or TB, I will rule out with FNSC or NAT or TB with cytopathology testing. If it comes out to be positive for TB, then it is TB treatment. If it is ileocecal TB, ileocecal junction is involved, it can be detected on CT abdomen or CT enterography, and there I can say that it is ileocecal TB and I will start a treatment for the child. Next. So ultrasound, which is a non-invasive test, is very important when it comes for abdominal TB. So either it can show abdominal lymph node, which is measuring less more than 15 millimeter in short axis, or it is conglomerated with central necrosis, or it has a moment of mesotic thickening more than 15 millimeter with increased echogenicity or ileocecal wall thickening. These are highly suggestive findings of abdominal TB. Then there are some non-specific findings which are also there, like the child has having interloop ascites, or ascitic fluid with multiple septation, abdominal uh, lymph node which are there less than 15 millimeter in diameter, and absence of any red flag signs are there. So you have to take it into consideration also the clinical findings and the UHG findings. So if it is ascites, the fluid can be sent for the NAT or TB culture. And nowadays there is no role of ADA. The ADA is not taken as one of the confirmatory. Because it was said that if ADA is increased, it is highly sensitive TB. Now we don't take ADA as one of the marker. So enlarged abdominal mass, if it is desirable, you can go ahead with USG guided or abdominal biopsy and send it for cytology. Again, there are problem is that if it is sitting near the big vessel, the abdominal mass, and if the radiologist is not confident enough, so there can be a problem because there are chances of puncturing these big vessels. And if it is accessible, then only you can go for the abdominal mass biopsy, or you can go for laparoscopic removal of this abdominal mass. It's a huge mass to rule out malignancy. So if it is desirable, you can go ahead with CECT. It is contrast enhanced CT scan of the abdomen or CT enterography. If it is available at your center, you can go ahead with this, and it is more sensitive for detecting the abdominal or what do you call it, intestinal TB. Then you can go ahead with USG guided abdominal mass or FNC cytology on adult culture. Options are the elio colonoscopy and then doing a tissue biopsy and sending for histopathology and for NAT, or laparoscopic tissue biopsy can be taken in some of the cases, exceptional cases. Next. Now coming to the last, this is one of the case scenario 4. It is a 7-year-old newly diagnosed CLHIV has come with a history of multiple swelling in the neck, armpit, and fever on and off about 10 days. Altogether, the child is hardly weight. Again, the weight is 19 kg. Height is 100. So he is having stunting also, because normally at 4 years you have a height of 100 centimeter. At 7 years, I expect the weight around 30 to 35 kg. So your weight is also affected, height is also affected. Vitals are stable, oral thrust is present. Numerous posterior cervical lymph nodes which are palpable, varying in size between 1.5 to 2 centimeter. The swelling of matted lymph node is palpable in the right axilla of size 3 centimeter by 2 centimeter. Hepatosplenomegaly was also present, and other system there was nothing, no other environment was there. So again, the question comes to our mind: is she a presumptive TB case? Next, yes, 4 is positive, then it is a presumptive TB case. And how do we further evaluate this child for TB? Next. So any lymphadenopathy is there, either it is a cervical, axillary, or inguinal lymph node. Then The first test which we can do in this, if the big lymph node is there and it is not near the vessel, then fine needle aspiration of the lymph node can be done. So extra-inguinal lymph node is more than 2 cm diameter, or rapidly growing lymph node is there, or it is asymmetric lymphadenopathy is there, or if it is tender, painful lymph node does not associate with a local infection. If it is matted, fluctuant lymph node, these are highly susceptible to tuberculosis, or it is a hilar or metastatic lymphadenopathy in the chest X-ray, or significant retrograde lymph nodes are there in the USG, or evidence of any abscesses, either cutaneous pulmonary. It is highly susceptible to TB, and you can send this lymph node for FNSC. And we were to send the FNS sample for NAT and AFB staining and histopathology examination also. So lymph node biopsy may be necessary for definitive diagnosis in some of the cases, because tissue diagnosis is the most important, even if you are clinically suspected. But tissue diagnosis, if it is confirmed, it confirms your diagnosis. Next. So there are also standard treatment workflow are released for the management of the pediatric tuberculosis. This you can go ahead. So persistent lymph nodes for more than 2 weeks in one or more areas, either it is cervical, axillary, or inguinal region. Size more than 2 cm, matted lymph nodes, plus or minus chronic sinus is there, with or without systemic symptoms such as fever, cough, poor appetite, and weight loss, with no evidence of any recent scalp or skin lesion. Because many times we have seen the draining area, the child has big cervical lymph node, there's a big abscess sitting in the scalp, which is hidden in the hairs. So you have to carefully examine the child. When the child has dandruff, sometimes chronic dandruff also we have seen big lymph nodes which are not going over a period of time. Cold abscesses chronically discharging sinus board, neck, axilla, groin, highly susceptible TB. So there you can go for lymph node aspirate, send for NAT, or particularly the challenge is for DRTB. Smear for AB can also be done. So desirable will be a lymph node cytopathology for NAT, lymph node biopsy. That is a core or extreme biopsy, both can be done. The chest X-ray is also going to support the diagnosis. Plus hemogram with peripheral smear. If there are any blasts are there and the big lymph node, then it will confirm your diagnosis that it is a malignancy. Then you can go for cytopathology also of that sample. So TBs are like if the lymph nodes are small, it's still less than 2 centimeters, that is 20 millimeter, and is less than 2 centimeters and are persistent for a long time, or months to years, without any systemic symptom. That is unlikely then TB. TB is unlikely in this child. Next. Again, this is a very important chart. So again, if you can go to the top, it's peripheral lymph node. It's more than 2 centimeters one or more sides. Left hand side, you go for chest X-ray. See if the chest X-ray is abnormal. Then, if it is abnormal, then go for sputum examination. And if it is TB detected, then yes, definitely it is a TB. If it is no, then you go for aspirate from the pulse sinus. And if no pulse, then do FNSC, same for NAT or the smear cytopathology. Then you, if it be detected on the smear, then MTB detected, and also look for any resistance there or not there. Right hand side, if it is matted lymph node or cold abscess sinus, then you can give a trial of antibiotic and see for any response. If there is response, then nothing gets to be done further. But if there is no response, then you can go for aspirate. So we have option of excision or core biopsy for all these lymph nodes, and AFP smear can be done, and further the child can be referred to investigate appropriately for higher center if required. Next. So criteria for diagnosis of probable DRTB in children, and this includes the close contact with a known case of DRTB, at least 2 years, close contact with a person who died of while on treatment was on TB, close contact with a person who failed TB treatment, or non-visible failure of the first line regimen, or previous treatment with the second line medication. This can be included in this category. Next. So this is our resources. India TB report, which was published in 2024, which is now available, and then National Tuberculosis Elimination Program of Pediatric TB Management Guidelines for 2022. Standard treatment workflows of India 2022. It's a special edition of pediatric and experimental TB along with the ICMR and Department of Health Research, MOH and Family Welfare is available. And lastly, the National Guidelines on HIV care and treatment, which can be also assessed. These all guidelines to read that we gain more and more knowledge about how to diagnose these best cases, so that we will report more and more pediatric cases which are normally missed. It's a tip of the iceberg. Only a few cases have been reported, but many cases are still missing. Next. So these are some treatment guidelines which are also available on the app. The National Guidelines for HIV Treatment are published by the NACO under the Ministry of Health and Family Welfare, which is available on the mobile app. You can download this guidelines in the PDF format. You can also get a notification and stay informed about the alerts and new features and other resources such as ART adherence calculator, serum creatinine calculator. It is also there with your YouTube links. You can easily share this content and you can scan and download this app on the Google Play or for the Apple users for the App Store also. You can use this. It is very user friendly, and I think many of you might be using this app. It's just for information. If you are not aware, this has been highlighted here. Next. So we want an HIV-free generation where no child should be suffering from TB, because TB is such a rampant disease. Right from birth, you have to see for immunization. If the child is HIV positive, if it's not significantly having severe immune suppression, definitely all child are encouraged for BCG vaccination. Suppose you see a child at a later age and he has not done BCG vaccination, then clinically evaluate a child. If it's less than 5 years, then definitely you do a BCG vaccine for that child. And second is that all vaccination apart from BCG should be given to the child. Then nutrition has to be recorded. On your daily visit, you see any child is having faltering growth or nutrition is not adequate, and properly do one-to-one counseling with the parents. Tell them the proper nutrition advice, nutrition diet, the child gets adequate weight. If suppose child is having malnutrition, then it is opportunity for the TB bacillus which is there in the child's body, which can get as opportunity infection and can present with the TB. And if the child gets TB, then he has to take the 6 months to 9 months of course, depending upon his TB. Suppose it is a TB brain, then it is 9 months to 1 year of treatment. Suppose it's only pulmonary extracellular TB, then it is 6 months of course. Then if the child is on TB, he is also receiving the ART regimen, then appetite is also decreased. So it's a vicious cycle for the child again to gain weight. It's better to catch early, treat early, and then prevent this TB, which is a deadly disease if you not treat them properly on right time. So this is what we are looking for, and I hope that today's session, which has been delivered, and will instill you to diagnose such cases, especially the children who are coming to your ART center less than 5 years of age, where you can further investigate the child. If his score is positive, even if his score is negative, then the child still be investigated. If child anytime develops this fever, cough, and persistent lymphadenopathy, and the child can be diagnosed and treated properly. Next.
Thank you so much, sir, for facilitating this session. I'm giving mic access to everyone. In case there are questions, please unmute and ask questions. Requesting participants to kindly unmute and ask questions. So I don't think there are any questions. Thank you so much for facilitating this session. Thank you to all the participants for patient listening and for joining in today. We'll conclude this session now. Thank you, sir.